Good morning, everybody. We'll be starting this poster podium presentation in community and social ophthalmology. So there are 11 presenters. The first presenter, I think, is not there. So we'll start with the second presenter. The presenting author is Dr. Saroj Gupta.
Can I share my screen, madam?
Yes, yes, yes.
A very good morning to all. My screen is visible, madam?
Yes.
Visible, you can look.
Just make a slideshow, sir. So today I'll be presenting my study on risk factors associated with development and progression of myopia. There's a rapid increase in prevalence of myopia over the last few decades.
Ma'am, your screen not visible.
Therefore, it has emerged as a significant public health problem. And in some parts of Asia, the prevalence is reported.
May I interrupt? Sorry, can we start the time? Yes.
Timer.
Should I start again?
No, you carry on.
So in some parts of Asia, the prevalence is reported to be as high as 90%. It suggests that besides genetic factors, there are some role of epigenetic factors also associated with lifestyle, which may have an important impact on myopia. So a study was done to determine the influence of outdoor activity on myopia onset and progression. It was a hospital-based longitudinal study, which was approved by a Institutional Review Board and informed consent was taken. Children with 7 to 14 years of age presenting with decreased vision or presenting with myopia of -0.5 verse were included in the study, whereas children with refractive errors other than myopia or family history of myopia or those with anterior posterior segment ocular disorders were excluded from the study. Total 580 children were enrolled. Psychological refraction was done in all children. Spherical equivalent was calculated and follow-up was done every 6 months for 18 months. And every visit, psychological refraction was done. The parents were asked to record the daily outdoor activity of the child in hours per day to school, at home, during weekdays and weekends, separately on a calendar provided to them. And they're supposed to bring this at every visit during follow-up. Outdoor activity was defined as a time spent in outdoor activity in daylight, like playing in ground or running or sports activities, etc. The outdoor activity per day was calculated by dividing the total hours of activity in a week by 7. Total 495 participants completed follow-up, so they were studied. Participants were divided into 4 age groups. This is the various methods which are used for data analysis. This chart shows the distribution of the gender across the various age groups. It shows the baseline spherical equivalent in various age groups and on follow-up visits. It also shows the mean outdoor activity in hours per day at baseline as well as in 4 visits across the various age groups. This is a correlation graph which shows the inter- and inter-individual association between myopia and outdoor activity in the 3 follow-up visits. It shows a statistically significant negative directional relationship between the outdoor activity and the myopia. And this central dashed line, it represents the overall negative correlation trend, means those who had more outdoor activity had less myopia. So after assessing the correlation trend, we assess the magnitude of relationship by a mixed effect model, which showed that estimated the effect of per unit outdoor activity to change in myopia in all follow-up visits. So it was found that in 1 hour, each hour increase in outdoor activity per day had a negative effect on myopia, but by -0.06 diopter, which was found to be significant. So outdoor activity was inversely related to myopia progression. So to our knowledge, this is the first hospital-based longitudinal study done on cohort of children from Central India, and the findings of our study are in correlation with all the other studies done in literature, like Sydney myopia study, the North India myopia study. They all showed that outdoor activity of more than 2 hours was protective against the progression of myopia. And the mechanism postulated is that this release of dopamine in response to bright light stimulation inhibits the growth of the eyeball. So our study has multiple strengths, like there are minimal recall bias in our study because other studies were done on questionnaire based. It's a longitudinal study, so it is easy to establish the causal relationship between the outdoor activity and the progression of myopia. The size is large, and limitation is that it is institutional in nature, so it doesn't allow to extend our findings to the general population. So to conclude, our study found a greater number of hours spent in outdoor activity had a protective effect on myopia, and the implication is that if we increase the hour of outdoor activity at home, at school, in children, it can be a strategy to prevent the onset and progression of myopia in children. Thank you. These are my references. Thank you so much.
Dr. Saroj, thank you very much for the nice presentation.
Thank you, sir.
There's one question.
Yes, sir.
This outdoor activity which will help in the myopia progression stopping, up to what age you are? What are the age factors you are?
7 to 14 years we have taken as we have studied in school children. So we've taken age group of 7 to 14 years.
So your studies, how long study you have done?
It was a 2 years study where we done 3 follow-ups every 6 months. It's a longitudinal follow-up study, sir, prospective.
So
Was there any
ideally,
difference
yeah,
with
very
the
good.
age group?
You should keep continuing the study for a long time so that we can know the exact health this can cause. Yes,
Yes, so
Soumya.
we'll do the study with a long-term follow about 3 years, so we can come out with the results.
Was there any difference which you found between the age groups of younger versus the older children?
No, sir, it was not found to be significant. It was found to be same. It was basically on the outdoor activity, the hours. Those who has higher outdoor activity, they had less myopia progression in our follow-up visits. It was found to be statistically significant, sir.
So age was not a statistically significant criteria in your study.
It was the amount, the hours spent on outdoor, especially in daylight activities, was found to be significant.
Right.
Okay, thank you, Dr. Saroj.
Thank you so much, ma'am.
Our next presenter is Dr. Jatinder Bali. Is he there?
Yes, ma'am. Thank you so much, ma'am. Can I share
Okay.
my screen?
Yes, yes. Please start. And please stick to time to all speakers.
Right, ma'am.
Speaker
I think somebody else is also sharing.
No. You have to go down to your right side.
Good morning, ladies and gentlemen. I thank the organizers for giving me the opportunity to talk to you about low-cost teleophthalmology clinic, or a better thing would be modifying the existing ophthalmology clinics. Sir, my internet connection is unstable. I may be lost. Modifying ophthalmology clinics with financial viability. I have no financial disclosures to make in this presentation. In the COVID pandemic, we are forced to change the way we are examining patients, and the telemedicine policy was introduced in March 2020, and our AIOS also came up with a tele-ophthalmology policy. But ophthalmology has unique needs. It requires high quality images, and we do in-office texts. And their smart machines as well as connected machines cost a heavy amount of money. So we decided to use the existing machines using a low-cost connectivity solution. What we did was we harvested the camera from an old and discarded telephone, and we connected it to different existing optical instruments. We used the discarded camera because we felt that cameras can be bought at a very these modules can be bought at costs as low as 2,500 rupees from open market. What we did was we took this discarded camera, we cut open a USB cable. There are 4 wires there. 2 of them are for carrying power and 2 carry data. And then using an OTG adapter, we attached it to a mobile phone, and using an app, the USB camera app, and we've created our own app also. So we used this, and we got the output on the telephone. This can go to a webcam server. After that, what we did was we used a single board computer called the Raspberry Pi. It can take 4. So we have 4 of these cameras on the same one, and these images you can access from anywhere in the world simply by changing the IP address. That means whether you are in US or in UK or in India, it does not really matter. After that, we did a pilot study, and we allowed 7 observers to acquire the images, and we got high quality images. We attached this camera to optical instruments like the slit lamp, the ophthalmoscope, the fundus camera, and we also used it as a standalone examination method. 7 observers, all of them found it. They managed to acquire the images, and we realized that it can be used as a standalone device also. The plus of this device is that connected machines cost a lot of money. There are other machines which can be used like the horoscope and the Zeiss Visiocam, but they are proprietary platforms and they are expensive. Our alternative costs between 125 to 250 US dollars, and these sensors can simply be stuck to the existing equipment. You do not need any special apps for this. We use Linux Mint with something called very secure file transport protocol daemon, and the database can be modified. We are using that. So we just need to use $250, and the clinics in India are already established. They can automatically become teleophthalmology compliant. In COVID times, they will allow us to provide protection to the examiner. These can go to remote areas because they are not power hungry. They can, in fact, this single board computer can actually run from a power bank. It runs on 5-volt 5-volt power, and the cost is less than 1/4 or even 1/6 of the existing proprietary products, and it is still a prototype. The cost will come down on commercialization. It's a workable and practical solution. Thank you so much. Thank you, sir.
Okay, thank
Thank
you,
you.
Dr. Jatinder.
It was very innovative indeed. So, what are the problems? Do you foresee any issues with this in becoming a mass scale product?
Sir, I think the costs will go down when we commercialize it. The only problem that we foresee is the bandwidths. The single board computer itself is capable of it has onboard Bluetooth, it has Wi-Fi, it can take a LAN wire into it, and the cost is around 5,000 rupees only. We're working on it, and maybe by the next conference, the biggest plus is that it is just the size of a telephone, and you can use it can be plugged into a telephone mobile power bank, and your system starts running and shooting the data.
Jatinder, next time you present this very nice innovation, please present images that you've taken in your data, so we can see it with our eyes that what hard work that you've done, and the images are so beautiful. So you
Sir,
put in the next presentation, put images.
Right, sir. I will, sir. I actually put the images, sir. There's a mishmash of images that actually got confused there. The one I wanted to show that, you see, there's this laptop screen, and behind it the patient is being examined, and we're using it as a torch. You just take the camera with the light close to the eye, and you get, because it's a 13 megapixel sensor that I'm using, sir. So I'm getting very bright images. The equivalent images I would get on a laptop, which would cost me around 1.7 to 2 lakh rupees.
Correct. Very
Okay.
nice.
Okay. Nice presentation, Dr. Bali.
Thank you so much.
We go to the next presentation by Dr. Manvi Sindel. Is she there? No.
Good morning, madam. I'm here, Dr. Manvi.
Okay. Dr. Manvi, please start. Please start
Yes,
your
ma'am.
presentation and stick to 4 minutes time of presentation.
Yes, madam. Surely.
And the coordinator, please keep the timer. We can't see the timer for question and for the presentation.
Yes, ma'am. The timer will be pinned while
And
the
please-
speaker will
Yes.
speak.
Please
And
pin the timer.
please mute everyone other than the speaker.
Yes.
Dog is barking there.
Ma'am, please share your screen.
Yeah, I'm starting. I'm starting my screen share. And,
Ma'am, is the timer visible?
yeah, the timer is visible, sir. Is my screen visible?
Yes.
Are my slides visible? Yes.
Yes.
So good morning, everybody, and it's a great pleasure for me to present this small work, but very significant work that we have done, which is to look at the awareness of retinopathy of prematurity and its related issues amongst the parents of babies who are being screened for ROP. And we conducted this study in South India. So, as we all know, ROP is a disease wherein we have abnormal development of retinal blood vessels, and a good screening protocol is crucial to prevent blindness, because unless the screening happens in a timely manner, and also unless the treatment when required is delivered in a timely manner, the babies are at a high risk for losing their vision. So given this sensitive nature, we have wanted to analyze the gap between the knowledge about screening of ROP amongst the doctors and the people who need to come, that is the parents. So the purpose of our study was to analyze awareness about ROP among parents in South India. And there's a very dearth of such kind of studies in the literature. So we believe that this will provide a lot of knowledge. So this study was conducted from October 2018 to June 2020. It was a cross-sectional study wherein we recruited 217 parents of babies who came to our institution or whom we screened at our outscreen reach programs for ROP. And a pre-validated questionnaire from a previous study conducted in California was taken and modified suitably to suit our Indian population. And the questionnaire had 22 questions regarding knowledge, attitude, and experiences of the parents. And this was administered to the parents by a trained paramedical personnel. So if you look at the demographic, we had 217 parents, most of whom were very young in age, 26 years at the mean, and 60% of them had an undergraduate education. 77% of the parents were aware that prematurity is a risk factor for ROP, but there was very low awareness about factors like low birth weight or oxygen exposure also contributing to ROP. While 54% knew that it can cause blindness, and that's only 54% knew that it can cause blindness, which is also very low. But the awareness that other complications can happen in premature babies or babies who had ROP, like strabismus, amblyopia, or glaucoma, was very, very poor. If you looked at their attitude, especially in attending the appointments, because that is the most vital part of a parent, that they need to bring their children properly to the appointments. And that 72% reported they had missed or postponed an appointment, whereas 77% had postponed and 2% had only missed an appointment. So this is also of concern, since we need ROP screening to happen in a very rigid time frame, especially for those babies who are progressing towards type 1 or ROP. And when we look at how well prepared they were, 74% reported that they required someone to read the hospital materials, whereas 35% had someone in whom they could contact for their child's eye care, and 44% did not have anybody whom they could contact. Parents reported that the ophthalmologist in majority of cases, that's 84%, and in 19% the pediatrician informed them regarding the follow-up schedules, and 59% agreed they were educated about the associated risk, and 43% were informed about the child's ROP status at discharge, and 54% reported that the hospital clinical staff stressed the importance of timely ROP screening. So when we looked at how the modalities were used to educate the parents, at 2 weeks of birth, which is before they needed screening, making them aware of the need for screening. And the second point is when they were being discharged, to emphasize it again, verbal explanation was the most common used modality. And in a few instances, especially at discharge, it was written down, whereas it was mentioned in the discharge summary that you need to get ROP screening. But use of videos or other online resources was minimal to none, actually. So the knowledge about ROP in the patients was quite poor. Attitude was also poor because majority had either postponed or missed a child's appointments, and they were not very well prepared to manage the child's health issue. And though there has been efforts on the part of the healthcare workers, that's particularly doctors, in educating the parents about the regular follow-up, this needs to be strengthened further to ensure good compliance. So future studies, we need to examine better practices at teaching parents, and also how these can improve their adherence to follow-up, and using of more interactive methods or maybe more videos and etc. to educate parents at points of care would probably be helpful. Thank you.
Thank you, Dr. Manvi.
Yeah, thank you, sir.
Socio-economic status of the parents of the children.
Yes, sir.
Have you taken this also in the criteria? Because as you said, talking to them was the most useful method. But nowadays, the young generation, they are more affected by the you can
Yes.
see videos at the online.
Yes, sir. Yes, sir.
Socio-economic status is also important.
Yes, sir. Socioeconomic. So we basically mainly looked at the educational background, sir. Getting information about that, which is what I said. There was majority of them had a undergraduate education. So illiterate and primary school were a very minority. 2% were illiterate and some 7% had primary school, whereas secondary school was in 30% and rest were undergraduate and post. More than 50% had undergraduate and postgraduate education. So that would affect. And yes, sir, socioeconomic data would affect.
Yeah, that's why they were more comfortable with your direct communication with them, not by the online.
Yes, sir.
If
Yes,
they would have been an educated person, they would have been affected very well by the online presentations also. Thank you very much.
Yes, sir.
Thank you.
Thank you, sir. Thank you very much.
Manvi,
Good day,
thank
sir.
you very much.
Yes.
In
Thank you, madam.
in this, I would tell that you should always uh, join your ophthalmological visit with the pediatrician visit. Then they
We do that,
understand the
madam.
importance. Because and
We
we have
actually,
to teach the our pediatricians also. Because
yes,
I
madam.
do this, our pediatrician is very aware. So you have
Yes,
to
madam.
make the pediatricians aware first.
Yes, we do that, madam. We do simultaneously do the pediatrician's visit and our screening where we go for outreach screening. Ma'am. We
Okay.
do coordinate.
Dr.
Yes, ma'am.
Okay.
Manvi,
Thank you.
it's a good
Yes.
presentation. Just I want to know
Thank you,
that
sir.
in your experience slide, knowledge, attitude, and experience, you said at discharge they were only around 49 or 53% were told about their condition about on discharge. Why such a low figure?
One of the reasons is that many of the babies were discharged before their actual need for screening date. That's one confounding factor here, because a lot of babies do get discharged somewhere around 2 weeks from the NICU. The little bigger babies, because as you know very well that in our Indian screening criteria, we do screen a little older and bigger babies also. So that was one of the reasons that they still had to have the screening. So they were not really aware. Some of the parents, though it was mentioned.
Your time is up. Sorry to interrupt.
Yeah, my time, sir. Yeah.
Okay.
Yeah.
Thank you very much.
Dr.
Thank
Manvi.
you. Thank you
So
very
we
much.
have our
Thank you, ma'am.
next
Yeah.
presenter. We have our next presenter, Dr. Aditi Ghosh. Please start. And please stick to the time.
Yes, ma'am. Are the slides visible? Ma'am, are the slides
Yes.
visible?
Yes, yes.
A very good morning, respected chairpersons and judges.
Can you
So
speak
I'll be-
loudly?
Yeah, am I audible? A very good
Yes, speak
morning, respected chairpersons and
Yeah.
judges. I'll be presenting a case report on Ayurvedic topical medication induced bilateral toxic endothelitis. So we know use of unprescribed Ayurvedic topical medication is a very common practice in India, and it is a major public health problem. Toxic endothelitis has been reported by BAC, riboflavin, amantadine. But there's a huge lack or lacunae in the ocular side effects of traditional medicine and their use. So we report a case to highlight this condition. So a female of 51-year-old presented with bilateral right eye more than left eye, sudden onset, painful diminution of vision associated with foreign body sensation and watering. It was not associated with any photophobia, history of trauma, HSV keratitis, previous episode, similar episode in the past, any ocular surgery or any other significant systemic disease. On a lot of coxing, she gave a history that she used over-the-counter topical Ayurvedic medication since 1 week prior to the onset of the symptoms. So here are the ocular examinations. So both eyes was 660. Little magnexa was within normal limit. There was no foreign body. It was reverted to check. The conjunctiva, minimal congestion was there. There was no foreign body. So now coming to the cornea, the epithelium was intact. There was mild stromal edema. There were descent membrane folds, as you can see, and fine capies. The corneal sensations were intact in all quadrant. Anterior chamber reaction was 1 plus and mild flare was there. Rest of the examination was normal. Although on fundus examination and our VR checkup, there was the FR was dull, foveal reflex was dull. So the OCT was done and there was an ERM existing in that. IOP was within normal range. So we went ahead with the specular microscopy. Because of the corneal edema, the counts were not very clear, but both eyes had pleomorphism and polymagnetism and a little bit decreased view due to corneal edema. Central corneal thickness was 590 in the right eye and 578 in the left eye. So we made a diagnosis of drug-induced acute toxic bilateral endothelitis. Treatment was started. The causative drug, as the patient was still using it, was stopped. Topical steroids, fluoromethalons, 6 times weekly taper was started, along with an antibiotic to prevent superadded infection. Lubricants were started, and sodium chloride 5%, eye drop 4 times, and sodium chloride eye ointment 6% was given at night as hypertonic agents. So on follow-up, first week, the vision improved to 612 in right eye and 69 in left eye. At 2 months, 69 in right eye. But it was because of the pre-existing ERM that it did not clear to 66 as it cleared in left eye 66. And there was a complete resolution of bilateral corneal edema. At 1 year, the patient maintained her vision, BCV of 69 in right eye and left eye 66 with no recurrence of symptoms. And we can see the specular microscope with normal cell density and morphology. And even today present at 3 years, the patient maintains her vision and her specular findings. So the causative agent, I'm not naming the drug right now, but it had a lot of onion juice, ginger juice, citrus lemon juice. The pH was 1.5, which was acidic. The ocular effect of above agents have not been documented in the literature, but we know that these traditional medicines do have an effect on the endothelium, and there's a lot of lacunae in the case reports. So to discuss, the corneal edema is based on few mechanisms. It can be either due to corneal epithelium damage, raised intraocular pressure, endothelial dysfunction, or idiopathic, which is without epithelium compromise. So in our case, there was no epithelium compromise. IOP was normal. So we contributed that there was a significant positive history of use of a toxic medication. We conclude drug toxicity as a cause of acute endothelial dysfunction in our case. So to conclude, use of unprescribed traditional Ayurvedic topical medication consisting of plant and animal material in aqueous media is a very common practice in India, and we do deal very regularly in our practice. So this just highlight the side effects of traditional topical medication and need of urgent medical care. These are the references. Thanks to my co-authors. Thank you very much.
Thank you, Dr. Aditi.
Thank
It
you,
was a
ma'am.
nice presentation.
Thank you so much, ma'am.
I just wanted to know what time after putting the drops, after how many days or after how many hours you saw this patient and took that specular microscopy?
Ma'am, the patient presented to us after 7 days. So this was all day one photographs we took that day only. And
It was a
after that,
7th day photograph.
7 day. That is the first day of presentation. The patient presented to us at 7 day, and we took the slit lamp photographs and the specular microscope on the same day.
Okay,
Prior to
that's why
starting the
those
treatment.
changes.
Yes,
That's why
ma'am.
those changes in the specular microscope.
True.
Otherwise, we don't expect day one changes.
Yes, ma'am. Exactly. Just we wanted to document before starting any medication.
That was nice.
Aditi?
Yes, ma'am.
Yeah, okay, sir. Aditi, it was a very interesting case presentation.
Thank you, ma'am.
Yeah, I just wanted to ask you that you said that the patient was on this Ayurvedic medication over the counter for some reason. Now, what was the reason that she was on Ayurvedic medication? Did you highlight that? Did you
Ma'am,
get
we
it from
asked,
her?
yes, ma'am, we tried a lot, but it was told that she was having some discomfort and just for freshening her up eye. That was the exact term used to make the eyes more fresh. One of her friends had asked us to use it. It's a very commonly used medication. We all know. We
Yeah,
all
it's okay.
face it.
You need not name it.
Yeah,
You need
I'm
not name
naming
it. But because tracing about the corneal edema that the patient had developed, I wanted to understand if there was a pre-existing disease.
Yes,
Anyway,
ma'am. We
thank you
tried
so
a
much.
couple.
It's
Thank
nice,
you so
interesting
much.
presentation.
Thank you, ma'am.
So we go on to the next presenter, Dr. Utkarsh Rai. Please share your screen.
Good morning, everyone. Is my screen visible?
Yeah, visible.
Yeah. Okay. Good morning, Chairperson and all the judges. I'm here to present my paper on the association of kidney and eye disease, which has been correlated to an iceberg. To begin, as we all know, there's a common fall hypothesis that the human eye and kidneys share similar structural, developmental, genetic pathways, especially with respect to the vascular networks, filtration barrier, and the RAS hormonal cascade. Even the vasculopathies like diabetes and hypertension also affect both the systems similarly, if not equally. The ocular manifestation could be the result of the primary nephropathy disease or the secondary effect of the renal failure or the complication of the treatment modalities to manage the CKD. The nephropathy and retinopathy usually go undetected until the disease is well advanced. There have been previous studies linking the two systems, most significant of which was the retinopathy in chronic renal insufficiency cohort study, which determined that the eGFR of less than 30 ml per minute per body surface area was associated with 3 times higher risk of retinopathy than in patients with normal GFR. Even PDR and maculopathy could cause 5 times more blindness in diabetes with glomerulopathy than in normal subjects. Even hypertensive retinopathy is particularly more severe in severe renal failure. Retinopathies are typically asymptomatic in the most treatable stage and thus cause a delay in the diagnosis and significant visual impairment. 400 patients of diabetic CKD without any pre-existing ocular disease were undertaken for this study, and analyzed for any ocular signs, and any correlationship between the diabetic retinopathy and nephropathy was observed. It was observed that most of the patients in the study were males in the 4 to 6 decade, presenting late in the with advanced and stage renal disease. Most of the patients were asymptomatic, mostly had only symptom of blurring of vision, and more than 54% of the patients had never undergone any ophthalmical examination, which indicates the lack of awareness among the patients. Most of the patients had diabetic retinopathy, cataract, and maculopathy as the reason for their visual impairment. Diabetic cases of CKD were mostly presented with severe NPDR. Both non-proliferative and proliferative diabetic retinopathy were more common in the advanced stages of nephropathy. Even hypertensive CKD cases had more severe grade 3 and grade 4 hypertensive retinopathy among the maculopathy patients. DME and ARMD were the most common findings. Of the 400 eyes examined, as close to 74% patient eyes had some anterior segment pathology. As high as 87% had posterior segment pathology, whereas 67% had both the segment involvement. Only just 2.5% of the CKD patients had no abnormal ocular signs. As can be seen with this figure, the more severe and more higher grades of diabetic retinopathy were more commonly aggregated in the more advanced stages of nephropathy. Similar was the skewing seen with hypertensive retinopathy and maculopathy seen here. To discuss this was the first comprehensive analysis of the ocular manifestation in hypertensive and diabetic CKD and the association of nephropathy with the severity of the retinopathy involving the team of ophthalmologists and nephrologists in the Eastern India. We found a substantial evidence of close association between the kidney and eye disease, retinal microvascular changes like reduction of nephropathy. CKD in turn was associated with more risk of diabetic hypertensive retinopathy, cataract, and maculopathy. Both hypertensive retinopathy and diabetic retinopathy, be it NPDR or PDR, were more frequent and present in more severity in the progressive stages of nephropathy, with showing a very positive, significant correlational relationship. To conclude, in India, where there are more than 70 million diabetics and a substantial percentage of these cases would be progressively developing diabetic nephropathy and diabetic retinopathy, ocular examination is essentially warranted at regular intervals to prevent visual impairment. However, there are still no standard clinical guidelines for routine eye screening in nephropathy patients. There's a substantial need to screen these nephropathy cases to find out any associated ocular manifestations, however asymptomatic, to reduce the morbidity and disease burden of the CKD, as we can conclusively say that hypertensive and diabetic CKD cases are mostly detected in the advanced stages only when they are symptomatic optimally.
Sorry to interrupt, sir. Please, I'll request you to please conclude.
Please stick to time.
I finished my question. Thank you.
Okay. Any questions?
Only one thing I wanted to ask was that very nice study, very good conclusion, but majority are diabetes and blood pressure related. Did you find any nephropathy besides these two diseases causing the eye problems correlation?
Yes, sir. We did. We also found causes of analgesic nephropathies, or we had only few exclusion criteria regarding the nephropathy, as in any case of nephrotic or nephritic syndrome, or any cause where there is pre-existingly confounding disease which might affect both the ocular and the renal system were excluded. Other than that, many other causes, drug-induced analgesic nephropathy were quite common. Even infection-related nephropathies were also common.
Okay. Thank you.
Okay, the coordinator, we cannot see the timer on the screen. Maybe the speakers are also not knowing about the timer. Please make it visible on the screen.
Ma'am, timers are shown on the screen of the speaker. It's
yeah,
showing.
we can see it.
We can see it.
It's on the.
So please, speakers, please follow the timer. We have our next speaker, Dr. Ipsita Kutia. Please share your screen.
Yes, ma'am. Yes, ma'am. A very good morning, all of you. Today, I will be discussing about the ocular manifestations of sickle cell disease. The life expectancy of the sickle cell patients have been increased during the last few years due to expansion of the healthcare facilities, bringing together a concomitant increase in the number of long-term complications. So, vaso-occlusive process in the sickle cell disease has been recorded in various parts of the eye, like conjunctiva, anterior segment, vitreous, retina, and choroid. The aim is to determine the pattern of ocular manifestation in sickle cell disease and to specify those during the vaso-occlusive crisis. It's an hospital-based cross-sectional study of 103 sickle cell patients, 60 with HBSS and 43 with HBSC genotype over a period of 2 years. The detailed history regarding the ocular manifestation is taken. Then this study was approved in the HIMSR Institutional Research and Ethics Committee, and the authors report no relevant conflicts of interest. Then on inclusion criteria, sickle cell patients coming to the IOPD, then routine follow-up of the sickle cell unit of our institute, then referred from the medicine department and pediatric departments if more than 5 years. Then exclusion criteria and refusal to give consent, then patient less than 6 years, eyes with a history of serious injuries or extensive surgery, then diabetic or hypertensive retinopathy, TAC MRI, then ALS disease, sarcoidosis, infectious disease, ocular ischemic syndromes, etc. Then a detailed series of examination of all the patient was done. Then 204 eyes were examined, 102 left eye and 102 right eyes. And the initial pie chart, we can see 76.6% patients show the ocular involvement. And in the second pie chart, we will see females patients are more commonly affected. Then this distribution graph shows the females with the genotype HBSC are more commonly involved with a significant p-value of less than 0.001%. In the second distribution chart, we can see the age group 21 to 30 years are more commonly involved. Then various anterior segment signs like conjunctival cuscu vessels, coma sign, icterus, iris atrophy, and cataract are seen. And in the second pie chart, we will see the distribution of cuscu conjunctival vessels with the genotype, and that shows HBSC genotype is significantly affected with a significant p-value of 0.0. The various non-proliferative sickle cell retinopathy signs like retinal vessel tortuosity, Salmon patch, black sunburst sign, and angial streak are noticed. Then association of the retinal vessel tortuosity with the age group is found significant with a p-value of less than 0.001%. Then proliferative sickle cell retinopathy signs like C-fan neovascularization, vitreous hemorrhage, and retinal detachment were seen in various numbers of patients. An association of vitreous hemorrhage with old age group is found significant with a p-value of 0.026. Then association of C-fan neovascularization with age group 21 to 30 years was found significant. And similarly, anterior segment sign like iris atrophy was found to be more commonly involved in patients with posterior segment sign. With that means with proliferative sickle cell retinopathy. These are some photographs showing cuscu conjunctival vessels, then retinal vessel tortuosity, the second photos, and third photo shows Salmon patches, then sickle cell orbital crisis with periorbital inflammation. Then on discussion, various anterior segment and posterior segment signs were noticed. And it is important to we noticed an important event that a 11-year-old male child presented to us with sickle cell orbital crisis, that is with painful sudden loss of vision, periorbital inflammation, proptosis with restricted extraocular movements and Salmon patches in the retina. Then in a study conducted in the Eastern India shows that the conjunctival vascular sponge is seen in the 36% and other anterior segment abnormality in 16%. On conclusion, sickle cell patients with repeated episodes of vaso-occlusive crisis are more vulnerable to ocular pathology. So newly emerging ocular imaging techniques like HD-OCT and OCTA have revealed the microstructural features of sickle cell retinopathy. So counseling at community level, timely intervention, public awareness regarding the early ocular symptoms, and implementation of regular screening procedures can help to prevent a major share of ocular morbidities in sickle cell disease. Thank you.
That was nice, Dr. Ipsita.
Thank you, ma'am. Thank you so much.
Good presentation, Dr. Ipsita. Thank you.
Thank you, ma'am.
So we have our next presenter, Dr. Amresh Kumar. Dr. Amresh Kumar. Is he there? Hello?
I don't think
Dr.
so.
Okay, so we go on to the next presenter, Dr. Shraddha Patnaik. Dr. Shraddha Patnaik,
I
is she
see
there?
her name.
Yes, she's seen.
Yeah,
She's
the
there,
name is
ma'am.
present, but yeah.
Dr. Shraddha Patnaik.
Unmute.
Joined, but she's not there. Anyway, we can go on to the
Anyway,
next one.
so we go on to the next presenter, Dr. Divya Rai Chandani. Dr. Divya Rai Chandani, are you there?
Again, I see the name.
Yeah,
She's
it's
there,
there, but oh, please start your presentation.
Yes, ma'am.
Please share your screen.
Ma'am, it's not showing, ma'am. Just a minute.
Coordinator, please see what's there.
Ma'am, they are allowed from their own PCs. They can share the screen.
Okay.
Yes, ma'am.
Ma'am, is it visible?
Yes, ma'am. The slides, your share screen is working.
Okay.
I would request all the speakers to please keep their slideshow ready well on time.
Good morning, everyone. I'm going to present the current scenario of ocular morbidity and severe acute childhood malnutrition in central part of India.
Please start your presentation. We can
Presentation
see your
start karo
presentation.
Sir, is it visible?
No, Divya,
But your
आपका-
presentation is not visible.
your screenshot आ रहा है आपका. You double click over it.
Sir, is it visible?
No,
No,
you double click
no.
over it.
No, what
You have
you
to
do is
click.
you exit your stop
You
sharing.
close it, then reshare it. If we have time,
First, stop your sharing.
share it, stop sharing, then reshare.
Okay.
We have time, you do it. Yes, if you are absent.
Sir, is it visible now?
No, ma'am, select your presentation, not folder.
So when you say start screen sharing, they will ask you an option that share your presentation or share your desktop or whatever. So you say share your presentation, your PowerPoint.
So now is it visible?
Yes, it is visible now. Say thank to chairperson, that was so much.
Thank you, sir. Good morning.
Divya.
Sir, I started slideshow.
Yeah, just start.
Good morning, everyone.
Timer.
I'm going. Sir, can I start?
Yeah, timer start now.
Good morning,
Yes,
everyone.
yes.
I'm going to show the current scenario of ocular morbidity and severe acute childhood malnutrition in central part of India. Coming to introduction, childhood malnutrition is a major public health problem in India. It is one of the biggest contributor of under 5 mortality due to increased susceptibility to infections and slow recovery. As nutrients are required for the maintenance of the ocular health, so therefore ocular involvement is quite common. It had various presentation ranging from asymptomatic cases to permanent blindness. Objective to study the ocular morbidity in children 6 months to 5 years in severe acute malnutrition and to assess its prevalence and associated risk factors. Coming on to methodology, it is a hospital-based observational study. All children with SAM in age group of 6 months to 5 years who were admitted in pediatric ward or attending the ophthalmic OPD of a tertiary care center. Inclusion criteria, children whose parents were willing to participate in the study. Exclusion criteria, children less than 6 months and more than 5 years. Detailed history, complete ophthalmic examination. ocular adnexa as well as anterior segment and signs of protein energy were looked and posterior segment was examined. Data was analyzed using SPS software 20. Coming on to the results, a total of 100 severe acute malnutrition was enrolled. Out of that, ocular involvement was present in 72 cases, whereas it was absent in 22 cases. Coming on to the table 1, it's showing ocular involvement. Among the cases, majority of the cases were having the conjunctival pallor, whereas other findings were noted. Distribution according to anterior segment finding, conjunctival pallor was most common finding, and in posterior segment finding, retinal hemorrhages were most common, and in vitamin A deficiency sign, conjunctival xerosis was most commonly found, whereas keratomalacia and corneal perforation was present in 2 eyes. Studying the risk factors or showing the association with the socio-demographic and other variables, only the birth order and number of siblings were significantly associated with the ocular findings. Rest do not show any other significant association. Coming on to the discussion, since the prevalence was noted in 72%, Singh et al. Document prevalence to be 16.6%. Our present study prevalence was high compared to reference study, since in our study we included children with severe acute malnutrition having severe comorbidities, whereas in other studies which were done, they were done on totally malnourished children which were both acute as well as chronic. Coming on to anterior segment findings, conjunctival pallor was most common finding, whereas posterior segment retinal hemorrhages was common, and in vitamin A deficiency sign, conjunctival xerosis was most commonly observed finding. Similar findings were observed by Ahmed et al. In that retinal hemorrhages was most common in 4% cases. Anand Kumar et al. Documented conjunctival xerosis in 36% cases. Among the birth order and number of siblings, these were significantly associated as they were having higher incidence. Coming on to the conclusions, since the prevalence are noticeable and under 5 children forms an important part, so they should be screened adequately for early detection of ocular findings and prevention of vitamin A deficiency. Also, every child should be immunized, given prophylaxis for vitamin A. Training should be given to the health workers at primary healthcare level and counseling mothers on the feeding and preventable eye blinding diseases, also regarding the hygiene and early referral to the children with hospitals. Also, education of couple regarding proper nutrition of the mother and child should be encouraged not to have more than 2 children. Thank you.
Dr. Divya, thank you.
Thank you very much.
One question from you.
Yes, sir.
You have mentioned their involvement of 2 corneal cases, and there are 6 cases of retinal hemorrhage.
Yes, sir.
What we have observed till now, that more corneal cases involvement is more than any other thing.
Yes,
other
sir.
than the conjunctival xerosis without spot you already mentioned. What will be the cause of high incidence of retinal hemorrhages?
Sir,
What element deficiency must have caused it?
Sir, since most of the cases they are severely acute malnutrition, so they were anemic also. So iron deficiency was most common. So the cause of retinal hemorrhages could be anemic retinopathy, or it could be due to vitamin C deficiency leading to hemorrhages.
And what about papilledema?
Yes, papilloedema, as children were severely ill. Most of them were on the ventilator, and also some of them were having like meningitis, so they can have the raised intracranial tension as well. So papilloedema can be due to that also.
So it was not due to vitamin A deficiency.
No, it won't be due to vitamin A deficiency.
Yeah, it is an associated finding.
It is an associated finding because all the children were severely acute malnutrition. They have other comorbidities as well.
Okay.
Dr. Divya, how many patients were having meningitis?
Sir, meningitis, 10 children were there.
So, but you have 30% of patients with papilledema.
Sir, meningitis 10% was there, like, and some other children were on the ventilator also. Other associated CNS involvement was also there, like acute encephalopathy also.
Okay. Any more questions? So we can go to our next presenter. Dr. Deepak Mishra. Is he there?
Ma'am. Yes, ma'am.
Okay.
Good morning, ma'am.
Please start.
Okay, ma'am. Thank you, ma'am. Respected judges, good morning to all of you. I am the rectified AIOC member. My membership number is M12337. As all we know that teleconsultation exists previously in ophthalmology, but it is of not only concentrated only for the rural areas or for that. But in this COVID pandemic, this lockdown tell us many things. And the most important thing is to connect with our ophthalmic services or the people with of the distant area is the teleconsultation. And there was a lot of questions and issues related to teleconsultation during the first phase of the lockdown, how we have to connect to our patient. With this background, we plan a study that we have to do the audit of the patient of the COVID-19 who have consulted to us as a tertiary care center, what was their experiences and what was the main finding for them consulted to us. It was an observational clinical study done on the 387 patients who called us in a teleconsultation during the almost 1 year of 1 to 2 months of the timing, and the Regional Institute of Ophthalmology. We have excluded the patient who have come to us physically just because of the emergency, as we are running the emergency cases. All the genders and everything places were notified in a proper pro forma, and they have consulted us on call and the WhatsApp group. And before doing this study, we have taken the Institute Ethical Committee clearance and follow the declaration of NSQ. In our study, the female were less as compared to male. Exactly, we don't know what was the reason that why the male patient are calling more. That may be because they are having more familiar with mobiles. And the age group we have find out is there was a two peak. One was of the age group of 21 to 30. Most likely they are the youngsters and having more familiar to mobile. And another one was 61 to 70 years of the age group. That may be because of the follow-up patient and other thing. The chief complaint we have, the important one was the maximum number of patients were of follow-up who have called us for the previously treated or something else. Then the patient, second peak was the patient with computer vision syndrome, maybe because of the excessive use of gadgets and anything. And another findings were almost same, some have the redness, watering and foreign body sensation. In the follow-up patient, when we demarcated, we find out that maximum patient were of the glaucoma, 37%. After that, there are those who have cataract are planned for the cataract surgery. Third number were ulcers, refractive errors, retina patients and others. In the discussion, we found out only one study has been published at that time, that was the DAS, and they have only find out the patient on the telemedicine consulted for the foreign body. Now coming to my conclusion, telemedicine patient who has consulted maximum were of the follow-up patient. Second number, and those follow-up glaucoma patient predominates, and the majority of them called and send their images or the problems on the WhatsApp. And as a take-home message, I would like to say that this COVID era gives us a new tool of telemedicine, which is existing previously, but its importance we learn more and more in the COVID phase. And now we just crossed the second phase of the COVID. I don't know whatever happens in third phase, but if teleconsultation persists, it will help us a lot. Thank you, sir. Thank you, ma'am.
Thank you, Deepak. Nice presentation. One question from you.
Yes, sir.
You must be having some dedicated person for this telemedicine at your setup.
Sir, our is the Regional Institute of Ophthalmology, and our institute is having a teleconsultation center. It is a regional teleconsultation center for whole of the Purvanchal area. And we are coming, we have a separate given mobile number to all department, that this mobile number is given and our schedule is being displayed at the website, that at this time this doctor will be appearing. So they are calling according to our schedule, and we have that mobile number used every day.
And what were the limitations you observed what are the limitations telemedicine you have got?
Sir, the major limitation was that what the patient saying, basically what were their complaint, it sometimes not corresponding to the images they are sending. So they are saying that I am having lot of redness or anything, and when we ask for the image, then the images are redness is not present at that time. And second thing, sir, for the rural patient, it is difficult to advise them the prescription online. Although we are sending them the WhatsApp images, but most of them are not having the WhatsApp. So we have taken a liberty that we told them to write the things drug name in Hindi, so that they can write the name in Hindi and get it purchased from the area where they are getting the drugs.
Thank you. This is the future of the telemedicine, the future of the ophthalmology or any medical plan nowadays. Thank you. But you have to improve a lot over this. Thank you. Next, any other speaker?
Thank you, Dr. Deepak Mishra.
Can I ask a question?
Any other question? Yeah. Any other
Sure,
question?
sir. Sure, sir.
Dr. Deepak, how
Yes,
many
sir.
patients were asked to come to the OPD physically among the patients who called you?
Sir, at that time our OPD was closed. We see only the emergency cases. But
Yes. So how many patients needed a physical appearance?
Sir, almost 10 to 20% patient, mostly of those who are having the glaucoma follow-up, and one of two are having just immediately post-operative and complaining that huge redness. So we are afraid of end-op and other thing, then we called him. But the personal consultation is almost 5%, sir, not more than that.
Okay.
Yes.
So thank you, Dr. Deepak Mishra. So I think we can give a call to these three people who are absent.
Yeah.
Because we still have time.
Plenty of time.
Dr. Tathagat De, is he there? Dr. Amresh Kumar and Dr. Shraddha Patnaik. Dr. Shraddha Patnaik, Dr. Amresh Kumar and Dr. Tathagat De.
Dr. Tathagat is absent. So we should mark them absent now.
Absent, yes.
Tathagat is absent.
And Dr. Amresh Kumar, absent. Dr. Shraddha Patnaik.
Amresh Kumar absent.
Yes.
And Shraddha Patnaik absent. Okay.
Absent. So 3 absentee and 1 presenter who is not a non-ratified member. So we have to judge 1, 2, 3.
Thank you, Vanna, for thank you, Vanna, for moderating on behalf of all of the chairpersons. Thanks for the chairperson. Thanks to all the speakers. We are well in time. So now we have time to give the marks and send it back to them. We have to send them in within 10 minutes time.
10 minutes.
So I think we should leave now and we should do our homework.